Hello, and welcome to today's CAP Today webinar entitled Adapting Your Respiratory Testing Algorithm in a Changing Reimbursement Landscape. I'm Bob McGonigal. I'm the publisher of CAP Today, and I'll serve today as your moderator, and at the end of our formal presentations, I'll be leading a question and answer session. Today's webinar is sponsored by Luminex, and we're very grateful to them who've made this possible through a special educational grant from Luminex. Let me make a couple of housekeeping remarks. Today you'll be listening principally through your computer speakers. You'll see on your webinar screen the slides that we're having with our presenters. If you have a comment or question that you'd like to pose at any time during today's webinar, you'll see a Q&A box underneath the slides. You can simply type in a comment or a question at any time, and then we'll deal with those after the formal presentations in a session of questions and answers, and we hope to be able to get to all of your questions and concerns in today's broadcast. I do want to hasten to note that this webinar will be made available in full, both audio and all the slides, at captodayonline.com. We'll keep it posted for a year. We usually post it in about 7 to 10 working days after our webinar of today. I also need to point out that Cap Today does not endorse any products or services that may be named herein, and that any expressions of my own are personal and not those of CAP Today or the College of American Pathologists. And so with that, I'd like to briefly introduce our two speakers. Again, you'll hear first from Charles Mathews from Boston Healthcare, and he'll be followed then by Dr. Margie Morgan from Cedars-Sinai in Los Angeles. I'll introduce each of them in some greater detail when we begin. And with that, let me just say that Charles Mathews has a master's in public policy and works at the Boston Healthcare, which is a consultancy with a lot of emphasis on reimbursement. He's a vice president and has a specialty in diagnostics and clinical laboratory issues. So we're very grateful to have him here today, and he can begin his presentation now. Please go ahead, Charles.
Great. Thank you, Bob, and thank you to all that are taking time out of your busy days to attend. So the way we're thinking about approaching today is I'm going to provide a brief bit of landscape in terms of an assessment of where things are today in terms of reimbursement for respiratory testing. I'm also going to point to where things may evolve. And then I'm going to hand it off to Dr. Morgan, who's going to provide a deeper dive on the specifics of dealing with some of these challenges at a particular institution. So just briefly to introduce myself, I'm a vice president of Boston Healthcare, as Bob had said, and I've historically worked for IVD kit innovators, so people developing individual tests, but then more recently been working directly with labs, very often venture-backed labs that are bringing their products directly to market. And I've had the good fortune of working on a range of different types of assays, everything from as simple as ELISA to very complex molecular approaches involving multiplexing, and worked with some pharmaceutical companies that are also very interested in this space because they're working on things like universal flu treatments, those type of things. So I'm pleased to bring you some information that we've gathered in the context of looking at this space. So in terms of the disclosures and disclaimers, what I'd first like to echo Bob's comments. I'm going to be giving you some of my own opinions. Although this talk is sponsored by Luminex, I don't work for Luminex. I'm not representing them or their opinions. And I don't want to be giving you specific coding advice. As you know, in context of billing and payment, the appropriate thing to think about is each individual provider is responsible for how they communicate the work that they've done to payers and deciding the appropriate coding. I'm just going to merely present you some developments and updates on what's going on in the coding space. And then also I may be talking about the use of Luminex products. They may be FDA approved or by other regulatory bodies, but I'm not going to be getting into any regulatory issues. I'm focusing on reimbursement. And lastly, as a sponsor, Luminex is compensating me for this presentation. Okay, so in terms of the topics, I'd like to first cover a couple of slides on respiratory testing dynamics, so what's going on in this space and some of the issues that it presents for payers, and then talk about some of the coding options, where they've been historically, what have been some of the more recent things that have evolved, and where things may head, and then talking about payer coverage. So what are payers, both commercial plans like Aetna's, Humana's, United's, but also the Medicare program, how are they treating this type of testing? And then I'm going to conclude with some summary thoughts on the future of payment for respiratory testing. So how is that moving forward? Okay, so respiratory testing dynamics. So here's just a simple diagram that we've created just to illustrate some of the challenges in thinking about what's the right way to address and treat a patient population. So first, you look at the diagram at the left, you have different patient populations that could be comprised of a mix of different things, elderly, children, immunocompromised. Then you also have otherwise healthy adults. So one of the factors that clinicians will have to take into account is, okay, who am I testing? And then also the thinking about treatment approaches. So in some cases, you might say, this is an otherwise healthy adult, so I don't actually need to do testing and I don't need to do treatment. They probably this will resolve on their own. But there may be times when you say, actually the best course of approach here is to treat empirically. Based on signs and symptoms, I can determine probably what this is and now have addressed that. In some cases, you may want to send it off for confirmatory testing. So in some cases, the role of the test is actually after a treatment decision has already been made to determine whether or not it should continue or discontinue. And then the strategy at the bottom here, respiratory testing being at front. So the idea that you do a test first, and then based on the test results, if it's negative, go to no treatment. If it's positive, maybe do antiviral, isolation, different protocols. So this is the reality of the way testing has evolved. And ultimately, it seems like you would say, I test first and then make treatment decisions. But because of some of the limitations of test methodologies from an accuracy or clinical workflow perspective, we have a lot of decision-making being made on an empirical basis. And that's been one of the challenges of the space historically. Now moving forward, we have molecular testing coming onto the scene. And one of the things that's really exciting about it is it's very fast. It can provide faster time to result, they say, for example, than culture methods. It's very accurate, so it's highly sensitive and specific. And it has the potential to be multiplexed. And what I'm referring to there is the idea that you would actually test for multiple pathogens simultaneously, whereas historically you'd have to order an individual test, look kind of hunting and seeking for individual pathogens that may be the cause. Now, the downside of it has been cost, and this question of, okay, is much more expensive. Should I be doing this in all patients or maybe saving it for special patient categories? If you go back to this diagram, you'll see that certain patient populations that I may have a different predilection in terms of what my treatment approach might be, and the test may be more or less valuable depending on the patient population I'm dealing with, and that might reflect the justification for the cost. So some of the key questions here is, how will the evolving nature of molecular testing here, which is now adding more pathogens that can be detected in a molecular fashion, how will that actually change decision-making in clinical care? If we can get it to a point when the cost is justifiable, and we're now getting accurate and speedy results for a number of different conditions or different patient types, would that reduce some of this empiric therapy, maybe improve antibiotic stewardship, those type of things? Maybe it would change some of the decisions about isolation or admission to hospital institutions. So there's a question about where are the situations or patient populations where a molecular multiplex approach is particularly valuable. And this is where I see a bit of a challenge in terms of the current landscape. We've had people start to adopt the testing and perform the testing because of the availability. So in some ways, the technology has outpaced the supportive evidence that identifies these appropriate patient populations and the appropriate impact on clinical care. And so we're in a bit kind of driving and putting the car together at the same time, trying to figure out exactly how should this be used moving forward. And that's where that becomes an issue is when you move over to reimbursement. Payers obviously will have some questions about that. So I just plan to overview kind of where the coding options have been and what some of the recent developments are. So Before I get into that, I do want to note an important distinction that those of you that work in the reimbursement space know is a very important one, which is payment for care depends not only on the type of service that's being delivered, but also the setting of care. And in this diagram, you'll see that we have the hospital inpatient noted, as well as the hospital outpatient clinic, or physician office. You'll note that the three at the right are situations where coding matters, because you have a particular code, and there's usually a fee schedule that says, when I do this service, here's how much I will be paid. Now, in the situation at the left, in an inpatient setting, the actual reimbursement for the test does not exist as a separate standalone reimbursement. In fact, the value of the test should be embedded in what is called a diagnostic related grouping, a DRG. And so one thing I'll just caveat my discussion around individual codes and their values is to say that inpatient testing is treated differently. And there, the value proposition is very much around how does this help the hospital deliver the care in the most cost-effective way, whereas in other settings, it might be, can we receive additional reimbursement? Now, some of the complexity there is you could have a hospital ED. If someone gets admitted and stays overnight, then they could potentially be treated then as an inpatient. But if they are treated on an outpatient basis and sent home, then these codes would come into play. So this slide just diagrams some of the inpatient dynamics here. As you see to the right, as I said, when you're talking about a DRG situation, all of these different components, the drugs, the devices, the diagnostics, the nursing time, et cetera, all embedded in one single fee that the institution receives. And I gave you some examples of people being admitted with viral illnesses with or without major comorbidities and complications, just to give you a ballpark figure for what that total value is. Now, the diagnostic component is a very small component of this, but it would be something that would be factored into the overall valuation of that DRG. But this is where you start to decontextualize the individual costs of the test. You say, it costs me X amount of dollars to perform the test, rather than saying, am I going to get Y amount of dollars to get reimbursed for performance of the test, I'd say, is that cost worth it? Does it offset maybe some of these other component parts of the cost of providing care to this patient? So it's a different way of thinking about the value of a product in an inpatient setting. But when we move over to the fee-for-service side, and I'll talk about individual CPT codes, current procedural terminology codes, we look at some examples in terms of influenza and RSV. You'll see that they historically have been very methodologically based. So you'll see there are different codes for immunofluorescent or enzyme immunoassays. Shell vial even has a code, and there has been individual codes for infectious agent detection of flu specific to that, and then there are also ones for RSV. And so you'll see that the payments vary on the basis of what methodology is being used, with molecular being paid a higher amount usually, but the description of the service is very much tagged to what type of test are you performing. Now, in 2013, there were a few new codes that were introduced that were somewhat different than these other ones in that they didn't have individual values assigned to the codes. They actually were representative of a complete panel. And what was interesting about those codes was that they allowed you to describe not just the performance of an individual test for, say, flu or RSV, but they said, I'm going to now perform respiratory virus panel that includes multiplex reverse transcription, and it includes multiple potential subtypes of different types of things to be included. And there it would be scaled on the basis of, is it 5 to 10, or is it 6 to 11, or 12 to 25? What are the numbers of tests targets that I'm looking at in that particular panel? And that would allow you to scale that the payment for the testing based on how comprehensive of a panel you're performing. Okay, so then the question is, well, if we have these codes, what do payers do with them? Are they in fact paying these codes? So first thing I want to note is that we're actually, when we talk about payers, there are different types of payers. So, for example, there are, in this diagram, this is based off of outpatient and physician office visit surveys for a particular IC9 code associated with upper respiratory infections. You'll see that the majority of visits are actually people that have employer-sponsored commercial insurance. But you also see there's a substantial number of people with Medicaid, and also a 10%, about a tenth of the group has Medicare. So it's important to think about all these different payers in terms of how they're approaching this space. So the first thing I looked at was, well, how are commercial payers treating this? In particular, what do they think about this multiplex molecular testing? At the beginning, I mentioned some of the issues there around it's fast and more accurate and comprehensive from a breadth perspective. It involves much more pathogens than the individual ELISA tests, but it potentially adds some additional costs. So what do they think about this? Now, we looked at a number of different plans, some of the largest ones, Aetna, Humana's, and United's of the world, and we did not see much in the way of coverage policies. So our assumption there is that probably many of them have created what I call implicit coverage, which means they've added that code to their fee schedule. When it's reimbursed by a network provider, they will go ahead, or submitted on a claim by a network provider, they'll go ahead and pay that amount, but they won't review or scrutinize it very much. Now, there have been some exceptions. You will note here that Blue Cross Blue Shield of Kansas has created a policy where they talk about those three codes I just mentioned and said, we're going to review these for medical necessity on case-by-case basis. So they're not saying we're going to cover it, but they're also saying we're not going to cover it. It's kind of, we'll take it as they come. And then, similarly, Louisiana said, based on the review, we may consider the use of testing to be eligible for coverage, and they include respiratory valves as that. So they say, we think it could have some value, but they still have some questions looming in their mind. So I'd say the policies that exist today are rather vague in terms of their deeming this appropriate or inappropriate. And I would say, by and large, private payers have kind of held off on this, and they've probably just simply added the codes to their fee schedules. But we live in a broader context, and what has changed with diagnostic testing is that historically it was the backwater. So the payers did not spend much time looking at diagnostic test costs because, frankly, one cholesterol test is not going to throw them one way or another in terms of their annual spending or budgets in a given year. But then what has happened is we've had two things. One is we've had a growth in the utilization of tests, so the number of tests being performed is increasing, and then also the volume of testing that's high cost is increased. And so you'll see some of the data here pulled from this United Healthcare analysis of both the cost and spend for genetic testing and more broadly molecular diagnostics has increased in a number of categories, including infectious disease. And so now what's happening is commercial payers are looking at this and saying, can we be doing a better job of managing the appropriate use of molecular testing? And rather than spending willy-nilly there, start to say, well, these are appropriate uses of tests and these are not appropriate uses of tests. And one group in particular that has taken a leadership position in this area has been the Palmetto GBA MolDX program. For those of you that are familiar with Medicare, this is a group that has taken ownership of advanced diagnostic testing. It's one of the individual carriers that's responsible for part of the geography of the country, but they've taken a leadership role in diagnostic testing, and a number of the other carriers that are responsible for different parts of the country now look to and defer to this group in terms of advanced testing issues. And so they've looked at and proposed a local non-coverage determination for multiplex PCR respiratory viral panel tests. And the reason why they did that, you'll see it outlined here in the slide, is they say that some of the pathogens on these panels don't share overlapping symptoms, so it doesn't make any sense to include them all as one panel. And they say we're not sure about the performance of all these things. Are they just as accurate, or maybe the fifth part of the panel is not as good as the first part of the panel? And they've asked questions about what is the clinical utility of doing all this. So if it's more rapid and accurate multiplexed, that's great, but does it actually change empirical antibiotic use, or does it allow for more targeted approach to antivirals? How does this actually impacting care? And so they're basically putting a stake in the ground saying we want more evidence here, we want a better understanding of the justification for using this as a frontline tool. And so they posted this in the beginning of June. The comment period just wrapped up at the end of July. They have not posted the finalized version of this, but this is a really important bellwether for us to look at in terms of how will payers start to address this in the future. And it's important for us to understand how they're going to potentially adapt to this testing environment and potentially refine the appropriate use of these tools, because that's maybe the future of respiratory panel testing with commercial payers as well. So in this next slide, I'd like to show you some examples of where I think this could head. So looking at this slide, you'll see 4 boxes here, and down the bottom it could go from the most broadly permissive, which would be broad coverage, just anytime someone bills that code, I go ahead and pay for it, and this may be where we are in some ways today, moving all the way up to the very top, which would be, I say, appropriate viral panel pathogen testing is only appropriate in certain patient populations. So go back to what I was saying before, maybe it's only good in the elderly or immunocompromised, people where if you make a wrong decision on empiric therapy, it has potentially severe and catastrophic consequences. Or maybe only certain pathogens should be included. Maybe these ones have a well-established value proposition because there's a direct therapeutic impact, but maybe if it doesn't include certain pathogens, then, or maybe there's certain pathogens that are included in the commercial panels that are offered today that maybe have little evidence and therefore we're not going to pay for them. So where we think payers may limit their coverage is some combination of those two things. They may limit it to specific pathogens, or they may look at specific patient populations. Where I'm fairly convinced is that we're going to move away from where we are today, which is broad coverage, into something that is more restricted in the future. And I honestly think the challenge will be on the industry and those that are performing testing to develop evidence that shows the justification and the clinical utility of performing these panels and help identify the appropriate patient populations in a comprehensive way as possible to avoid a situation where payers arbitrarily limit it based on limited information. And this is part of the broader context of where diagnostic testing is today and where we need to head. Historically, diagnostics have been very site of care focused in hospitals, and the decision maker has been around the laboratory, and the value message has been around IVD metrics, so things like turnaround time or workflow advantages, footprint, broader menus. And the evidence development has been pretty minimal. It's been about this box is better than that box, and here's why you should use it, or maybe this result is concordant with another result. Where we're heading as an industry is more towards now these hospitals are part of hospital systems, and there's value assessment committees looking at these potential changes in workflow or testing efficiencies and trying to assess how is it impacting the overall delivery of care and the cost efficiency of that care. And it involves a broader dialogue between laboratorians, physicians, hospital administrations, and even potentially payers. And what the underlying need for all of that is going to be evidence showing the clinical utility and its provenance of care and how it's actually impacting that. And so I urge those of you that are doing RVP testing now to be thinking about what are ways I can take the patient populations that I'm testing and develop evidence that could be useful to these different stakeholders that support its value on an ongoing basis. So some of the takeaways here are that given the rising cost and complexity of molecular testing, they're focusing on different areas. So we've already seen this in GI pathogens. I'm predicting that respiratory might be coming down the pike. And then payers may want to limit it to certain pathogens or patients. And inpatient, you might still have the same questions. Remember, inpatient is a different paradigm now, not so much payment on a CPT code basis, but still asking the question about, is the cost justified? Is there clinical utility that's associated with using multiplex molecular testing as opposed to individual tests or just doing culture? And then labs that are offering a one-size-fits-all panel, so you could say, this is my one-and-done panel, everyone gets this panel, that may make sense in certain settings, but in other settings it may make less sense because you'd have a challenge of justifying all the components of those panels in, for example, an otherwise healthy adult population, or justifying the specific pathogens that are included in it if they're not, for example, prevalent in your institution. So one of the things that's emerged is an idea of maybe there's a model where you can be flexible in terms of defining what the panel offering looks like and defining what the cost of that offering is. That's been referred to as flex pricing. I think that's an interesting way that could potentially allow labs to scale their offering to what is covered or cost effective in this future landscape. But more needs to be seen there in terms of how private payers will adapt moving forward. And some of the implications of some takeaways for this audience in terms of what you can do is that you can identify specific applications of the molecular respiratory testing which can impact care in a cost-effective way. So say, you know what, we're not necessarily testing everybody that walks through the door, but we've identified these people need the most, and we need to be judicious about use of antivirals in, for example, the elderly population. So let's do it that way. Let's collaborate with physicians, and let's have a dialogue between the laboratory group and the clinical group about how are you going to use this information, where is it going to move the needle, where is it going to be impactful, and then let's work together to maybe collect some evidence around the clinical and economic value of that. That does not have to be a giant prospective randomized controlled trial, but it could be simply a retrospective observational study of care patterns both pre and post the introduction of multiplex panel testing. And it could be focused not just on the analytical accuracy of these tools, but what is the clinical utility? How is it changing behaviors within that institution, having this information in hand? Because I think if you talk to laboratorians and doctors, they get it. They understand that rather than doing serial one-off testing, one test followed by another test, and trying to guess what a patient has, knowing it all at once leads to a clear decision. I think we just need to hone and articulate that value message and move beyond, well, it's an added cost at the front to, okay, it changes clinical care, and that clinical care actually is more cost-effective than a hunt and peck kind of approach to identifying a individual respiratory pathogen. And it needs to be adapted to different stakeholders, be it the payer or the hospital system. Okay, that's the brief summary of my talk. And as Bob said, these slides will be posted, and this webinar will be posted. So, Bob, I'll turn it back to you so you can tee us off into our next session.
Charles Mathews, thank you very much for that lively presentation. I want to apologize to you and to the audience for anyone who may have had some audio problems, particularly in the opening minutes. We will certainly get those corrected, and I'll make sure that all of today's participants receive an email which will tell them when they have the full audio and slides up on CAP Today online, which, as I said, we anticipate happening in about a week to 10 days, and we'll ensure that the audio is complete and intact for that recording. In the meantime, if you have any questions or comments that you would like to make, remember, you can type them in the question and answer box that's right below the overhead slides. And at the conclusion of our formal presentations today, I will lead a question and answer session. And now I'd like to turn to our second and final presentation of today. Dr. Margie Morgan is a diplomat of the American Board of Medical Microbiology. She's a Ph.D. and a professor of pathology and laboratory medicine at Cedars-Sinai Medical Center in Los Angeles, where she's also the scientific director of microbiology. And she's going to now be addressing the selection of the respiratory testing algorithm in the face of some of these reimbursement issues that have been raised so well and in such detail by Charles Mathews. So with that, Margie, please take it away.
Certainly. Thank you very much. And I thank you for being here, for my ability to be here this morning and to talk to you about some of the things that we've faced. With all of these things that Charles has been talking about, it's taking me down my lane of horrors of all of the things that we now have to consider. I think I'll move my slides forward here. This is where I work. I work at Cedars-Sinai Medical Center in Los Angeles, and I have this slide because I think understanding my particular situation and my patient mix maybe makes my angle of my story a little bit more understandable and some of the choices that we've made more understandable. Cedars is a large tertiary care teaching hospital. We have a lot of immune-suppressed patients, which will pay into our decision-making. We have cardiology, orthopedic surgery, the general services that most of your hospitals have. We have an unusually large elderly population at our hospital, and it's quite unusual, a very, very low pediatric population. So this kind of feeds into some of the decisions that you will hear me talking about of how we've made choices in trying to make more valuable choices in our respiratory testing. We also, of course, have emergency departments, urgent care, and clinics, and we offer an outreach testing for physician offices surrounding Cedars, and that's about 30% of our volume. So we also have to consider outpatient testing in our respiratory algorithm as well. Our microbiology laboratory is on campus. We're fairly large with 55 employees, and we have 24/7 coverage. Now, I've been in microbiology a long time, more years than I would like to say, but let's just say it's been a long time, and I was raised with the auger plate. And I still love auger plates, and there's very meaningful things that we can have from the auger plates. But even though I've been in microbiology so very long, I had to move toward automation and accept that non-culture-based technology is really the movement of microbiology. But you know, that's not been the only change I've had to make. It's not just been from auger to molecular. It's also becoming more of a businesswoman. I need to adapt these changes of technology and assess their valuable impact on what could be in our testing algorithms, be able to produce data, work with people that can do that if I'm not so capable, and make economic sense of our testing. So that's the way I see things movement, not just to molecular, but to being more business-wise with the use of our molecular testing. And in doing so, I can't do it alone. I think that's one thing I have learned so much over the last maybe 5 to 7 years is a microbiology laboratory standing by themselves does not have nearly the power of one that has a group of collaborators. And I've been so fortunate to be able to collaborate with these people in my list here, my stewardship pharmacists, infection prevention, infectious disease physicians, administration. Oh, they've become very important in some of my decision making when it comes to cost. And targeted physician groups, particularly dealing with the hospitalists, which have become making a very major impact at Cedars. So in doing this, then, I've had to move forward and I've been urged to produce rapid, targeted, and accurate results. One of the things that has really helped a lot in making some of these decisions has been our very, very active antimicrobial stewardship group. I can't stress how important I think a collaborative stewardship group can help in making all different kinds of decisions. Yes, their major emphasis might be the proper use of antibiotics, but in all of our discussions in doing so, we also can discuss the proper economic use of things like respiratory pathogen testing as well. Our antimicrobial stewardship group, of course, is keyed on sepsis. We've done rapid ID and resistance marker detection from positive blood cultures. We're moving into direct pathogen identification and susceptibility testing directly from positive blood cultures. That's the complicated things, but we've gone back and reassessed our timeliness of reports. Are we really turning these things out rapidly enough to be valuable, to be useful? Also, do physicians understand our reports? Maybe so, maybe no. We need to make sure that we have not comments that just maybe laboratorians can understand. We make sure that physicians understand. And you know, something that's happened at Cedars recently is we now have a portal open that patients can view their own laboratory results. So we have to make sure that the laboratory reports are suitable for for patients to view as well. So this has become much more complex than it has in the last few years. We also need to move forward with improved test utilization. We need to have laboratory offering the best testing options. We believe we should limit our testing to what the physician is actually ordering. We have attempted through our stewardship efforts to monitor and limit physician orders with testing algorithms, and we've even developed computer hard stops for things such as repeat tests. We also have a very well-established lab test utilization group that's collaborative with many players from many different disciplines that also work on this effort. So what do we hope is going to happen from all of this new collaboration and effort? Well, we hope, of course, that it's going to improve the use of antibiotics. It's going to improve patient outcomes with earlier patient discharge. And very, very important right now, it's going to create a more reasonable economic model. I think two things have really become very, very important, maybe over the last 3 to 4 years: the patient and the insurance. Patients have become far more cost-sensitive to laboratory testing, far more knowledgeable of what they expect, the turnaround times they expect, They can view their results in their patient portal. Why isn't my test performed yet? It's amazing what knowledge some of the patients have. Also, a lot of these patients have suffered through high deductible insurance plans over the last few years. And so costs have become a very, very important issue to the patient. And I think we can never leave that thought. We are here for the patient, and we have to understand the difficulties some of these costs might incur upon patients with these high deductible plans. The other thing that has happened is insurance plans have changed themselves. And we have gone through a lot of shifting with the Affordable Care Act. Previously we had a 40% Medicare, Medicaid versus 60% private payer insurance mix. But over the last few years, we've seen a 10% shift in that. Now we're at about 50-50. So this 10% shift can reduce our reimbursement in the laboratory and once again make us rethink very seriously the economic policies that we have in the microbiology laboratory. So what's the current scene in the microbiology laboratory? Well, if you walk into my lab right now, and I'm sure in all of yours, we have many, many instruments. But a lot of those instruments are kind of one size fits all. They have fixed panels with a fixed price. There's many numbers of targets on the panel. Maybe it's more than you reasonably need, and maybe it's a lot more than the physician actually ordered. We also may need multiple instruments to fit our needs if we don't want to use a one-size-fit-all panel. So if we want to get multiple instruments for select targets, that can also be a very expensive approach for the laboratory and also for the patient. I think it's mind-boggling sometimes when we step back in the laboratory and look at how much time and money we actually spend on training on instruments, the paperwork, we have to document competency, our proficiency testing, quality control needs, and all of the inventory management and ordering that has to be done for multiple systems. This expense can also be passed on to the patient by having all of these multiple platforms being performed. Now, in my setting, where I have 30% of outpatients, when I have the costs that incurred to outpatients become a very, very important consideration. So what do I see that are some movements in the microbiology? Well, I need to step back, and I need to make sense of all of this movement to molecular testing. Does migration to these syndrome-based testing panels really better our needs of proper utilization and targeted testing? Am I doing the right thing? Am I choosing the right panels? Should I choose large multiplex panels for one size fits all, give you everything you need with the first push? Or is it better to have separate panels, such as for stool pathogens, to have separate bacterial, parasitic, and viral panels? The same for sepsis. Should I split them up rather than having one huge panel? For respiratory pathogen panels, should I offer a one test for all, or should I have an option for a step down that just offers influenza and RSV? There's really a lot of thought need to be put into this now, not just on the value of the patient and the value of the test, the needs of the physician, and also what is our economic model. The competition of products, of course, are based on the needs in the laboratory, the needs of our physician, and the pricing. The ultimate use in our laboratory is always based on quality, and there's many quality products out there right now to choose from. But in the end, it is also based on pricing. So there's an increasing need for both clinical and financial data to support the creation of these new molecular programs in our laboratories. Every time we start a new program at Cedars, I have to present a business plan. I have to present how we are going to use the specific panel or instrument that we're choosing to use, how it has gone through my collaborative groups, and there's been a consensus of opinion that this will offer value to the patient. And I have to provide cost data on what overall costs will be incurred in the laboratory, of course. So we get back to our respiratory pathogen testing, and there's some real diagnostic challenges with this kind of testing. It's a common site for infection. There's a large number of specimens that we need to test, at least in my medical center, because I have a huge elderly population and an immune-suppressed population. Symptoms alone sometimes are not sufficient for clinicians to determine etiology and optimal patient management. So this can lead to overprescribing of antibiotics, the one thing that we don't want to have happen these days. Also, there's a wide array of respiratory pathogens with seasonal variations. So what drives the MD ordering panels? What's in the physician's head? Why do they sometimes want certain things and not? Well, season has one thing to do with it. Of course, influenza A, B, RSV testing in the middle of the winter is the primary thought. That's a seasonal approach. Patient demographics. Sometimes a very, very, very ill inpatient needs more testing for respiratory pathogens than possibly a normal host in the outpatient setting. The underlying conditions, such as immune suppression, and the pediatric population also may have some special testing needs. Also, our hospital committees, particularly in my medical center, the infection control people have a lot to say in what we do in our respiratory pathogen testing, and they're major collaborators in what we choose to do because they want to make sure that patients are under the proper respiratory precautions. And then, of course, there's desired turnaround time. Nothing is ever fast enough, but physicians really do value more rapid testing. If we can turn around our testing in a rapid way, then perhaps we can truly limit the use of antimicrobials by providing a viral etiology where antibiotics can be stopped. So the antimicrobial stewardship challenges of respiratory pathogen testing then becomes massive. Uncomplicated upper respiratory tract infections in the outpatient account for 25 million physician visits annually in the United States. The large majority of infections are in pediatrics or viral, also the majority in adults. However, most patients are prescribed antibiotics, and this is thought to probably be most usually due to not having rapid testing, finding a viral agent, and then feeling comfortable stopping the antibiotics. Community-acquired pneumonia that require hospitalization among adults is substantial and is markedly higher among the elder adults. Viral pathogens also have become more frequently detected than bacteria due to indirect and direct effects of successful vaccination programs for bacterial pathogens. So rapid and accurate testing could help to an accurate diagnosis and lead to decreased antimicrobial use in the hospitalized population as well. This is just a slide. I think we all know the seasonal variation of viral pathogens, but maybe not every time of the year do you need to test for all pathogens. And I think that's just bringing that point with this chart. And moving on to my story. So, this is the story of respiratory pathogen testing at my institution and how we're trying to seek out the most meaningful and cost-efficient method. So by me showing you my progression from 2012 to current, maybe you can draw some similarities and see how we've used some of the principles that Charles has been talking about to try to improve what we're doing in the laboratory. So let's go back in time to 2012 to 2013. We had the two tests that we were offering in the microbiology laboratory. The BD Directogen, which was an enzyme immunoassay for influenza A, B, and RSV. We offered both tests. This was what we were performing for our emergency departments, urgent care and clinics during flu season. They were very aware of patient billing issues. They wanted to offer a relatively cheaper test, shall we say. They needed it to be rapid because they wanted to make decisions while the patients were still in the ED or in these clinics. In-house, we're offering the BioFire Film Array Respiratory Panel. This panel, of course, tests for multiple viral pathogens and some bacterial pathogens. And it can also, we were using it, though, for multiple purposes. We were using it in our immune-suppressed population for the overall panel and all of the viruses, but we were also using it on our inpatients that were just coming for rule-out influenza. We did not feel at the time it was appropriate to use this panel if a physician just ordered testing for Mycoplasma pneumonia or all they wanted was the single target of Bordetella pertussis, so we were sending out those as reference lab tests. So, what did they think in 2012 of this little algorithm that we had created with collaboration? Well, our pharmacy thought it was good for the immune-suppressed patient. It offered a full panel for their needs. If they found a pathogen, they could stop antimicrobials. Administration? Costs a lot of money, Margie. This panel is very expensive. Infection control? Well, it's a good panel for our immune-suppressed, but can you not offer us something for just influenza and RSV? Because that's what we're really most interested in most of our patients. And the outpatients were, oh no, this is a very, very expensive panel. And we actually received phone calls, particularly one I remember from a mother who was virtually crying over the telephone about the cost of testing her twins for influenza in the outpatient setting using this panel. And so it was both wonderful in certain respects, but caused us some issues in others. So let's move on. 2 years in the future, with work with our collaborative group, what did we do? We moved on to the BD Veritor once again to offer EIA for our emergency department. We offered the BioFire, but in a different way in 2004. We were only offering it for pediatric and adult intensive care units for our severely immune-compromised patients, where they desired testing for multiple viral pathogens. During this season, we introduced the Verigene RV Plus panel for influenza A, B typing, and RSV. We used this panel selectively for our general medicine units, the adult intensive care units where they were only interested initially in ruling out influenza or RSV. We also made use of it in pediatrics when they wanted just to rule out influenza, and we were using it for outpatients. We were not getting the same complaints from the billing of this limited panel as we were from the expanded panel, so we were offering it to our outpatient physicians if they thought it would be useful. We still sent single target requests, such as Bordetella pertussis, to the outreach laboratories. Administration was happier. Using this algorithm, we saved $250,000 over the previous year because we were not using the extended multiplex panel for all of our needs. ID and infection control were happy that we could selectively rule out influenza. Pharmacy was fine. They still had what they needed with the extended panels, and our outpatients were much happier with the way we were billing. So let's move forward. That's 2014. Let's move to 2016. We still needed a quality test choice. Microbiology budget considerations were becoming paramount. We had to eliminate some of our expensive rental contracts. Elimination of send-out tests were desirable. We would rather have a model where we did not have to train and have competency in IQCP and all of these things going through multiple instruments. And we were getting increasingly concerned with the cost to the patient because many, many patients were having the high deductible policies, and it was, over the years, had been the most common billing complaint into my microbiology laboratory. So taking all of these things into consideration, we wanted to continue to offer a better plan. So we thought about looking into a unique way, a new way, and that would be flexible testing and pricing. So we thought that using a flexible panel like the Luminex system offers would give us the ability to adapt to physician ordering patterns, do initial request, run one panel, and then release the, say, just influenza A or B testing initially, and then if needed, open up the rest of the panel if that was so desired. We could order a test and bill a test that was specifically ordered by the physician. We had a potential to eliminate a send-out test. We could potentially reduce some laboratory costs because we would be dealing with one instrument and a maintenance contract, less cost in supply inventory, and we would have to spend less time in testing QC performance, training, and competency, and we would still have a reduction in turnaround time. In the past, when we had our two-step algorithm of using the Luminex RV Plus for influenza A and B, on occasions physicians would call back and then still want the massive full panel on the BioFire as well. So that would delay our results. We'd have to go back, find the specimen, and rerun the specimen. If we had just one panel that we could open up the panel and release the results, that would save us in turnaround time. So how does the Veregene RP Flex work? Well, the Veregene Respiratory Flex panel, as you can see, offers as a multiplex panel. It offers 13 viral targets and 3 Bordetella targets. The specimen is nasopharyngeal in universal transport media. It's one product, one platform that is run in your instrument, covering the continuum of multiplex respiratory testing. There's 5 possible testing categories, which I have outlined there in the red blocks. So these are the separate testing categories that you can arrive at a customized pairing, so you can develop pretty much a custom panel as you would see most fit for your hospital situation. So how have we used this? Well, we've used influenza A and B with subtyping, the entire viral panel, the entire viral panel plus Bordetella, and then the Bordetella species by itself, and that eliminated our send-out issue. Why these subsets? Well, these were in sync with our historical ordering patterns. It believed to be understandable options that physicians could kind of understand, and we had collaborative discussions with our physician groups, and they thought this was a good way to start. But that doesn't mean you couldn't alter it in ongoing years as your needs change and your value and the economics change. You could potentially redo these panels. So how does this work? Well, you run your one panel. The physician orders, say, influenza A and B. So you load the one panel into the Luminex instrument. You say that you want it to be run for influenza A, B, RSV. So that will be the only results that are released from the run of that 13 viral target panel. You will receive and report those results. So if people could say, okay, the physician could say, that's all I need. It's positive for influenza A. Or the physician could call us back and say, Margie, thank you, but all of those targets were negative. Could you please open up the entire viral panel so I am able to see all of the results? And that's what we would do. So how did this do with our financial impact of testing? Did this help us in any way? Well, let's review my cost, okay? So let's look and let's see if I can use my little arrow to help you here. Maybe not. That's okay. I don't need to use the arrow. Look at the first line across and you can see the $455,000 amount of money. That's how much my viral panel cost me in 2014. If you go down to 2015, when we instituted also using a breakout influenza A, B, RSV panel, you can see, yes, my cost did go up, but you can see I was also tested 1,000 more panels that year with only an increase in cost of $5,000. Also notice that my average cost per test went down to $100. In the next year, 2016, once again, I had the breakout influenza A, B, RSV panel, and then also using the full BioFire panel. and noticed that my costs did go up, but also my numbers had gone up 900. Notice I'm doing more respiratory viral testing. Overall, it's starting to cost the laboratory more money to do viral testing. But because I was implemented the RP Flex panel for influenza, my average cost per test was continuing to go down a little bit. But let's move on to what I did this year. In 2017, using the RP Flex panel, how did that help me financially? Well, if you look at that data, you will see the average price per test in the center. And if you go to the bottom, you can say my overall price per test now has gone down once again from the $97 I had in 2016 to where my average price per test is now $72 by using the RP Flex method of initially testing for influenza A and B and then opening up the panel if necessary. So you can see the great cost advantage that these algorithms have presented for us. Also notice on the right, very far right-hand side, I had almost 4% of just Bordetella only ordered, and so that was also a great cost savings and time savings for us as well to be able to do that testing in-house. Also, with our testing algorithms, you can see how the numbers of tests, of course, are higher in the winter. They, of course, go down as you head into summer, and you have less respiratory pathogen testing. And you can also see a subtle shift from just testing for influenza A and B. And as the year moves forward, when you have more of a mix of different kinds of viruses, how you're having more of the total viral panel initially ordered or opened up for review. I would be happy to answer any questions you might have about this if I did not explain it very fairly. We're charged a base price for the influenza A, B panel testing, and then you're invoiced monthly with your use. I'm not a great person talking about money. I'm sure that your local rep could talk to you much more clearly about how all this works. But there's a base pricing, and then you add on an invoice every month for the additional testing that you do. And we will address that in a later slide a bit more. So this is just how our ordering for RP Flex has gone. You can see that we predominantly, due to our algorithms and education, have attempted to do more targeted and meaningful testing and concentrate on influenza A, B testing, particularly in the winter months. And this is just another breakout of showing the tallest one, of course, is influenza A and B testing, and then the broad panel versus the Bordetella testing. And you can see how how you kind of shift in your usage as the needs and the value of the different tests appear as the viruses are in your community. So I hope this kind of makes sense to you, how you can make use of this type of panel. Questions I thought you would ask, and I'm sure there might be many more. If we offer an MD the choice between the targeted flu RSV initial Luminex panel and also on the same order screen a broad respiratory viral panel, will the MD not always just order the broad panel? Well, sometimes they think more is better and that wins out, but we've tried to prevent this approach by education and discussion with physician leaders. And we also had administrative approval to initially test for influenza A, B, and RSV during the peak season in our general medicine units, with the ability for the physician to open up the panel if necessary. So we instituted education, policy with our administrative groups as part of our stewardship committee, and developed a plan and a policy for the use of this panel to make it even more cost efficient and more valuable for what we really needed in our targeted testing. How did we educate our MDs on appropriate ordering? Once again, collaboration. I think it's difficult for microbiology sometimes to educate physicians. We made great use of our infection prevention practitioners and nurses. they helped us speak to physicians, go out to intensive care units and around the hospital where they have very, very good and well-known collaboration with nurses and physicians on the floor, and they helped us. We also carefully placed the Rule Out Influenza RSV on the top of the respiratory panel ordering screen, so that would be the first choice. We visited specialty groups. We sent out flyers. We did all the routine educational things, but to my chagrin, and I'm sure you'll say the same thing, sometimes the flyers and education materials can just pass across the desk and not be read very well. So I really think the real strong point was our infection prevention people going out to the floor and speaking for us. Is it unethical to test a broad panel where the instrument could detect a positive target, but the information remains hidden? The way we feel at Cedars is if we're testing a panel, yes, it may contain multiple pathogens, but if we're testing and releasing the organisms that are specifically requested by the physician, we do not feel it is unethical. Also, we are in no way preventing the physician from opening the panel and looking at the other pathogens. All they have to do is give us a phone call and say, please open up the panel. We would like to view the other viral pathogen targets. And that is very easily done. Has our billing department had any issues handling reflex testing and or CPT coding? We've not experienced any issues with the CPT coding or the on the flex panels or the patient billing. We did have some initial issues with some of the invoicing monthly, but we worked with our local representative to better understand the invoices, and after a month or two, we were very clear on how all of this was being handled, and now we seem to be moving forward without any problems. And with that, I will end, and I thank you very much for listening to me go on about our respiratory pathogen algorithms and story of our testing, and I will hand it back to Bob for any possible questions. Thank you.
Dr. Morgan, thank you so much for that wonderful presentation. In particular, I'm very grateful for you covering so many of the frequently asked questions that may well have arisen here. Let me remind the audience, we are at the top of the hour, but I'm going to continue with at least a few questions here. And I'd be grateful to you if you still had questions about the costing of this by analyte and by panel. If you'd like to refine those questions in light of Dr. Morgan's slides in explanation, please go ahead and send us yet another question or comment. I'm going to start as I give Dr. Morgan a chance to catch her breath and perhaps get a sip of water with Charles Mathews and ask you, we've had several questions regarding post-transplantation patients. What is your experience or what is your view in terms of the payers covering this sort of testing for post-transplantation patients?
Yeah, that's a good question. I would relate it back to what I was saying earlier in terms of defining the appropriate clinical positioning of the test. So there's a couple different ways you can do that. One is the types of patient populations that are appropriate for testing. So I mentioned elderly, pediatric. I would put transplant as immunocompromised in that group and say that there may be a different clinical justification for testing that group in a more comprehensive way. There's less room for error, so to speak. The other dimension that I think comes up a lot is the appropriate timing of testing. If you think about what I was outlining at the very beginning of my talk in terms of test and treat versus treat and test, there are some issues around when do you want these results. If you want to make it before a treatment decision, then there's a certain urgency, and there the speed of a molecular approach can be of value. But if you're simply doing confirmatory testing or maybe now monitoring a patient, you don't have any actual cause to suggest that this is a very serious condition and it needs to be addressed right away, that you're just simply looking for signs of infection, then maybe it's more difficult to make a case for molecular there, because other methods that may take longer but still be highly accurate might be, and less costly might be well worth it. So So I think that's part of a couple of the dimensions we need to think about. Which patient populations need to be tested? What are the clinical scenarios? And what's the appropriate timing of using this test, which I think Dr. Morgan has outlined some of the issues that she dealt with there at Cedars.
Thank you. Margie, would you like to comment briefly on the question of post-transplantation patients and reimbursement?
I can say that we do have a lot of post-transplant patients. We can have some very long-term hospitalized patients. Oftentimes, they do not necessarily develop viral respiratory pathogen issues because they've been in hospital for so long, but they're all DRG'd type patients. The reimbursement, of course, is not on per test, and they do present particular problems for us. We do, of course, all of the testing that is necessary. We have to trust our physicians on what they feel is the value of our tests, and that is a huge cost issue, I should say, at Cedars because of our huge immune-suppressed population.
I can well imagine. Thank you very much. I have one quick follow-up for you, Dr. Morgan, on your presentation. You referred to opening up the panel, and could you elaborate a little more about what that really means in practical terms, or explain a little more fully?
Certainly. I'm sorry if I didn't do that well. Let's just start with, say, you're running the Luminex cartridge in the instrument, and the physician ordered influenza A, B, RSV, which is our initial panel on the Luminex test, on the RP Flex test. So we run the test, the panel is completed, and we release the influenza A, B, RSV. Okay, so let's say it's all negative, and Dr. Z calls us back an hour later saying, thank you, but could you now open up the entire panel? I'm interested in the other pathogens. And so the person would go back to the instrument. You do a few computer manipulations. You would release the rest of the viral targets, and then those would go into your computer system. So you do not see them initially, but you unmask them in the testing system, and then they are available to be released. Does that make a little bit better sense?
Yes, it does. I think. Okay. Thank you very much. Charles, would you like to comment?
Well, yeah, I'd just like to interject. I think one of the questions that might come out around that is how do you reflect that appropriately in CPT coding? So I'll say the structure of the CPT coding is if you're running less than 5 at once, and it's appropriate to use individual codes. So let's say you do flu and then RSV, so you use the flu code and the RSV code individually. But then once you're across that 5 threshold, now you're in the realm of those panel codes that I showed. So depending on the number of things that you, quote-unquote, open up, or payment is on the basis of the information you provide to the clinician. So if you provide 5 to 10, now you're using the first code. If it's 6 to 11, so the coding is scaled in a way that you can build the appropriate code depending on the number of particular pathogens you're related. So that's how you can match your clinical offering to appropriate CPT coding.
Yes, Charles, and you're exactly right. So we had to develop separate panels for releasing that were associated with appropriate CPT codes.
Thank you very much. Charles, while I have you there, we have a question that I think needs to be asked and answered. It's as follows. Currently, does a Z code need to be registered for the infectious disease by molecular technique? And also, will there need to be then evidence of clinical utility to be submitted to Molecular DX for payment? I hope that's clear.
Yeah, no, that is clear. There's a question of kind of the process here. So yes. Where MolDX is today is they are saying we are unclear about the value of this, and so we are actually looking at that, and we've prepared a draft policy. They have not finalized that policy. The context of that policy is still being discussed. In fact, my understanding is that there is now a work group that has been formed involving various laboratory specialty societies, including ASM and others, to help define what an appropriate cohort looks like for testing. And then the likely outcome of that will be MolDX will create a policy that says, okay, we believe testing is appropriate for these patients and in these situations, and that is still to be defined. Once that is defined, the individual laboratorian will not need to demonstrate it on a per claim basis. They will simply say, this CPT code is covered for this ICD-9. Those of you that are dealing with the MolDX program and in the territories that are covered by MolDX know that they do rely on the McKesson Z-coding system, which is a separate and parallel system which adds greater granularity to diagnostic testing. So it is fair to expect that the MolDX program, once they promulgate the final version of this policy, will ask people to apply for Z-codes describing their test offering. The concept of flex testing and flex pricing may struggle with the Z-codes because the Z-codes are very specific to a particular type of test, and it's kind of, so you may need multiple Z-codes. I don't think that they've gotten there yet. Thus far, what they've done is send a shot across the bow saying, you know, we have questions about the clinical utility of this, and so now there's a dialogue about what is the appropriate use of these tests that is trying to be resolved.
I'll ask both of you a very quick yes or no question. You first, Charles. Are you optimistic about the outcome of this MolDX initiative?
I'm optimistic that they will resolve to conclude that there are some appropriate uses. I think we'll move away from the world in which it's broad coverage of everybody for every purpose without much review or scrutiny. But if you think about some of the patient case profiles that Dr. Morgan reviewed and some of the ones I mentioned, I think you can say there are certain situations, e.g. immunocompromised, that you can say these people present with similar symptoms, and the challenge here is making a rapid and accurate decision about it. So I'm optimistic that that's probably where not only MolDX but also commercial payers will land. It's kind of, and you saw that in the one slide I had that scale, where commercial payers will probably end up kind of refining the appropriate patient populations. I don't think that they'll ban panels altogether, but I do think we're in a bit of a situation where we've gotten the technology has kind of outpaced payers' ability to understand its value, and so now we're going to need to identify and define some particular use cases that are valuable, and then get those payers on board for that. Then we might again loop back to, okay, well, let's start to broaden that over time. Well, the cost of the technology is coming down, the clinical efficacy is being demonstrated in these groups. Maybe we start to add in some other groups. So it may be kind of a bit of a roller coaster here that we have to work our way through.
Thank you. And Dr. Morgan, briefly, would you like to opine as to your optimism or pessimism about the outcome of that?
I think I don't know this as being optimistic or pessimistic, but I think we need to work with our physicians in better ordering. I think I don't want to get myself in trouble here with all my physicians who I dearly love, but I think that sometimes they do not take a very they overorder. Let's just leave it at that. Sometimes they overorder, and perhaps the tests are not necessary to be done. And I think that we all need to look at what we're doing, laboratories, and I think it's very, very important that physicians take a look at what they're doing, because we would not be having such issues in my particular laboratory with cost and some of these issues if we had more prudent ordering. And that's a very, very difficult issue to deal with. But I think we all need to step back and take a look at what we're doing, not just the laboratory.
Very good. And if I may add, I think that's a very wise insight. I will get back to some of this in a moment, but we have many questions for you, Dr. Morgan. In your ER and urgent care clinics, are you still offering enzyme immunoassay flu tests?
Yes, we're offering the Veritor test. Our ED is an independently tracked group, and they want this test performed, the Veritor EIA, because of its speed and its inexpensive billing.
Okay. Thank you very much.
They do realize there is a loss in sensitivity over a molecular. I mean, they are very aware of molecular tests. They're also very aware that many of their patients coming into the ED are cash pay, or poorly insured, and they want to make sure that they're not that they have a reasonably good test performed that is reasonably priced.
I understand. Thank you very much. Would you say your overall volume of enzyme immunoassay flu tests has fallen?
Yes. No. I would say in the peak influenza season, they use it a great deal in the ED to guide them on therapy for either influenza therapy versus antimicrobials, and also if they're going to admit the patient to the hospital, sometimes they'll do a quick influenza EIA for respiratory precautions.
Thank you very much. I want to go back now to a question that's been asked multiple times, perhaps in some different ways. But several people have indicated in our audience that they're aware of payers, that they see the data that's being generated by many new laboratory technologies as problematic. One questioner raises next-generation sequencing as a typical technology that may affect us there, since many of the targets are incidental and may or may not have clinical utility.
Can I just say that, we do NGS at Cedars as well. I think that I think some of our technology has exceeded the capacity of the users of the tests and the understanding of the tests and the full value of the tests yet. I think the value's catching up with the technology.
Okay.
And I think we're about maybe 2 to 5 years out with NGS. I think it has huge value, but I'm not quite sure that the value's meeting with the technology yet.
Very good. And Charles Mathews, would you care to comment on this same general question? Because I think it's quite a good one.
I agree with Dr. Morgan's points, and I think it's an important issue to think about as a pathology and laboratory community. Is the technology is outpacing our ability to produce clinical utility evidence and define appropriate patient populations. That we see this in broad tumor panels in the oncology space. We see it now in respiratory and multiplex testing. You can bring it over to the GI pathogens as well. So then the question is, where are we going to land with all this? I think from a laboratorian's perspective, they say, well, if I can provide more information and achieve economies of scale by doing multiplexing, then why not? I think payers are still very much in the world of each individual analyte or pathogen that you add to a panel adds additional cost. And so something like next-generation sequencing, which is very disruptive and allows you to look at a whole bunch of things all at once, there's just questions about the depth and breadth of information provided and what the utility of it. One clear line that I draw is are these variants of known significance? So if it's something that you find that no one else has ever had before, then is it really clinically actionable at that point? This is where the lines between kind of research and clinical activity start to blur. And you think about it in the infectious disease space, what happens if we had full sequence information on people and their microbiome and everything when they walked in the door? Yeah. I think our infection control and ID docs would kind of scratch their heads and say, wow, I don't even know what to make of this. I do see a vision of a future in which the antibiogram is actually phased out by having sophisticated testing data as what really bugs are going on. And because the antibiogram is in some ways is kind of a temperature gauge is what's going on. If we actually knew on a per patient basis based on actual samples what it is. But, there's a lot of technological, scientific, and candidly payer and health economic questions about how to get there and is it effective. And maybe it's even a public health issue of maybe it's not important for payers to be paying individual hospitals for this data, but now CDC wants to know this and aggregate it for public health purposes. So there's a lot of bigger issues that we kind of get into, but I agree with Margie's comments that near term it's kind of we need to align the technology and the support for it, and maybe some of that is reining in our physicians about appropriate use of it, kind of saving the super tool for situations where the super tool is really justified.
Thank you. Let me now pose the penultimate question for Dr. Morgan. When we look When we consider broad spectrum testing, mycoplasma and chlamydia are often included in the panel. If you begin moving away from the broad spectrum panel, what is your strategy for replacement testing for atypical bacterial targets?
Well, unfortunately, they're not any good FDA-approved tests at the moment, and we're not into LDTs in my laboratory. I don't mean to put down a target of the chlamydia, but I don't believe we've ever detected one in the thousands of panels that we've run. Mycoplasma pneumonia has not been a major issue in our hospital, but we do send it out as an individual test because we do not feel that it is, particularly in an outpatient setting, we do not feel it's appropriate to bill for a large multiplex panel when only one single target is being requested. So perhaps we're odd, perhaps that is not what everyone would do, but we do not feel that it is ethically correct to test for numerous targets that were not requested by the physician.
Very good, thank you. And now, because we are moving along towards the bottom of the hour, I'm going to pose the final question to both of you. And this is sort of in a very general way, but I think it addresses a lot of the central topic and concern of today's webinars. What advice would you give to laboratories of any kind, whether at great tertiary centers like Cedars-Sinai or in a community hospital setting? What's the best single first steps for labs to do to get out ahead of these sorts of questions, both with the technology and, of course, the payment? I'll let you answer that first, Charles Mathews.
Sure, I would just echo Dr. Morgan's comments. The first step is actually getting out of the laboratory itself and establishing lines of communications with the physicians that are ordering these tests and making treatment decisions. I particularly enjoyed her comments around getting the nurses involved and having them help communicate the value, because I think a lot of times we fail to recognize the important role that they play in kind of guiding decision-making, those type of things. So, yeah, it's about establishing a more collaborative approach to this rather than having a walled-off lab and a walled-off physician practice, building a bridge between them and saying, okay, who are the people where this is really going to be useful to you, rather than ordering it willy-nilly on everybody. What are the appropriate patient populations? What are the clinical actions that we're going to take? And then putting together a joint value proposition maybe to hospital administration, infection control, that says, okay, if we have more of a tiered type of testing program that allows us to dial in different tests and save these panels but uses them in appropriate patient populations, then this is where we're going to get the most value for it. Then I think there's an important second step of not just implementing the program, but also tracking some metrics about it, saying what's working, not working, be able to make refinements. And then finally, I would urge you to, if you are in the midst of one of these programs, consider collaborating with your peers and publishing some data around this. I think there's one thing that payers are looking for is payer-reviewed publications that describe the value of this over time. If we can get, and it's not up to any one of us to do it, but if as an aggregate, multiple institutions are publishing papers about here's its use in immunocompromised, here's its use in the elderly, here's its use in pediatrics. And if you start to aggregate those things, I think eventually we'll reach a tipping point with payers where they say, you know what, I get it. Doing more up front is better. And I'm not going to argue about the size or the specific inclusion of the panel. I mean, this is one issue I have with the way MolDX has approached everything. It's these Z-codes of incredible granularity about exactly what is being performed at each time. And the reality of it is, at a certain point, we're going to just conclude it's actually just better to be more comprehensive at the front if it's cost effective. And once we demonstrate that, and I think a number of use cases, and publish that, and then I think that we'll reach a tipping point, and the payers will basically get off our backs and let us do what we do best. But until that point, I think it's up to us to work together to develop that evidence.
Charles, thank you very much. And Dr. Morgan, I'll give you the last word on that topic, or anything else you'd like to add today.
Well, I think Charles summed it up very nicely. I think he's basically telling us to get off our rear ends and go do something, aren't you, Charles? And I think you're exactly right. We probably haven't done enough in microbiology to show utilization data and good value of some of the testing that we're doing. I think microbiologists have sometimes not been very good promoters of what they do. We're the testers, we're the thinkers, but we don't necessarily promote or advertise or let people know the value of what we're doing. So I think that has been an ongoing problem. And I think the second problem also is microbiologists have tended to close the door, do our testing, and not collaborate. And I can't stress how important it is to collaborate with all the people, particularly your administrators that handle the money, your infection prevention people, even more so sometimes than just strictly ID, your intensivists, your hospitalists. They have different viewpoints, and they can see things very differently and bring up ideas that laboratorians maybe have not even thought of that's involved in some of this testing. So I think we need to open our doors. Charles, I'll try to write something for you, and I think we need to continue collaborating and try to do the best we can.
Thank you very much.
Thank you.
Thank you very, very much. I know that we have quite a number of questions that we didn't have time to get to today. I can assure you that we have a record of those, and we'll do our best to get them answered. I'd also say that Luminex has a very fine field force that can be very helpful with many of your questions, and I'd recommend you to them. With that, I do believe it's about time that we need to wrap up. So I would like to particularly thank Luminex for their sponsorship of today's program, which has been really very, very excellent. I'll remind you, apologize for any audio problems we had, but I'm assured that when we post this in its entirety in about a week or so, all those audio problems will not be apparent, so you'll have a great chance to hear everything clearly in its entirety. With that, I want to thank Charles Mathews of Boston Healthcare and Dr. Margie Morgan of Cedars-Sinai for two wonderful presentations. And most of all, I want to thank all of you for joining us today on this CAP Today webinar. We're very interested in what you think about these. We're grateful for your participation, and we hope to speak with you again very soon. With that, I'll close the webinar. Thank you very much, and have a nice day.